I'm calling this presentation a progression of books about medicine, and I'm dedicating it to Dr. Jimena Páez of Venezuela. The books I want to discuss start in about 1991 and progress up until this year itself. And these are books about medicine and about my experiences in medicine that I hope will be enjoyable and instructive. All of these books, except one, have been translated into Spanish by Dr. Páez. And I want to thank her very much for the translations and for hard work in making these available in Spanish. And the next slides will show, the next three slides will show the names of the books and her translation titles for each of those books. I also want to thank the kind letters from her medical students who read and reviewed the book called Med School. And the next slide shows the names of those students that wrote me very nice letters and telling me how much they enjoyed reading the book and how much they got out of reading that book, Med School, which is also translated into Spanish. There are two versions of Med School. This is the first one, which was self-published. And then later I did a revision of it, only a slight revision, and this came out just this past year ago. So those are the first two books. I'm not going to discuss them in details. Those are stories of going to medical school in 1951 to 1955. I relate serious and funny stories during those 4 years. I think you'll find those 4 years very, very different from med school today. Things were stricter. We had very little technology. Everything was hands-on, physical examination and listening to patients. And those are very instructive, and I hope I've carried some of those letters forward in those two books. With that behind us, I want to move now to this book, which is the heart and soul of my career in medicine, Symptoms of Unknown Origin, a Medical Odyssey. When I came out of medical school, I was what might be called a biochemical doctor. I believed everything could be converted into biochemistry, and that every disease would be definable by a test, and that every disease would be treatable with medicine or with surgery. It might be called the strict biomolecular model of medicine. This book traces my steps from that view to a very open view, a very whole model of the human body and disease at the end of this book. In the first presentation in this book, I relate a story of going to medical school and seeing a professor bring a woman into the classroom who was paralyzed. And this woman was drooped over in the wheelchair, all to one side. Slobber was coming out of her mouth. She couldn't speak. And he told us this woman had myasthenia gravis. Myasthenia gravis is a neuromuscular disease in which the transmission at the neuromuscular junction is not working. Not only had science uncovered the cause of this disease, but they had gone to formulate a medicine that cured the disease, at least temporarily it would control it. So with that, the doctor took a syringe out, filled it up with physostigmine, injected the woman, and in a matter of minutes, she not only was no longer paralyzed, she was standing up, doing a little jig on the floor, and he had cured this woman from complete paralysis into an active human being who talked and could thank us for being there to share her story with us. Somehow I thought all of medicine was going to be like that. There'd be a disease, there'd be a defined cause of it, there'd be a defined treatment for it, there'd be a drug or an operation, and it would all be very simple. It was just a matter of science catching up to discover all of the different diseases. I went through residency training with that view. I came out of residency. I, in fact, got drafted into the U.S. Army Medical Corps and was stationed in Texas. And the patient I saw there opened my eyes to a much broader view of medicine. This young girl was just turned 13, 12 or 13. She had juvenile diabetes, we called it then, which is now type 1 diabetes. She made no insulin, was insulin dependent, and she would swing from very low blood sugars in the morning until very high blood sugars at night. She would go from hypoglycemic coma into diabetic ketoacidosis. Within 12 hours, she was swinging, and it was what we call brittle diabetes. I worked with her for weeks and weeks and weeks, had admitted to the hospital repeatedly. I could not get any kind of control. I changed her diet, I changed her insulin. I did everything I could. I called my old chief in New York to get instructions from him. I had her seen by consultants. Nothing would smooth out her course in diabetes. And so one week she didn't show up in clinic, the next week she didn't show up in clinic. Things went by, and after a month I was sure she either died or was going to another doctor, or I didn't know what. Then one day she showed up in the clinic, all smiles. Her mother was all smiles. And she said that the daughter had had no more hypoglycemia and no more ketoacidosis, and had very smooth control of her diabetes ever since a little girl moved in next door, and this patient had to take care of the little girl who was 4 or 5 years old, change her clothes, look after her like a nurse, and the family gave her a little kitten. So with a kitten to care for and a little girl next door to care for, somehow the biochemical defects of diabetes smoothed out and went away, and she was under good control. Some sort of psychosocial influence had happened in this girl. I never would have thought of it in a million years, but I realized then that there are factors outside the people and around them and with acquaintances and stresses and whatnot that influence disease very strongly and greatly. That set me on a course of trying to figure out what that was all about. I then went into practice, and this is all related in this book, in Selma, Alabama, with the man who delivered me as a baby. So the difference between his way of practicing and my scientific way of practicing was quite different. He got sick, and I took over his practice, and I noticed that almost half the patients he saw did not have the disease he had diagnosed. The fact is, they didn't have any medical disease. So he would give these patients medical diseases and manage them that way. I thought it was just an odd characteristic of the doctor until I got into the academic world in Birmingham at the University of Alabama, where I found that many, many patients were carrying diagnoses of diseases they did not have. That set me on a course that I would follow over the next 40 years, trying to figure out what it is if patients have symptoms of the disease but don't have the disease. If they don't have a medical disease, then what do they have? That's the question that's driven me all these past 40 years. I decided then to examine a series of these patients who carried diagnoses of diseases they didn't have, and to experience them as patients to see if I could arrive at some understanding of what they had if they didn't have a medical disease. So I collected 150 patients in series. It's not a random sample. It's 150 consecutive patients that had symptoms but no definable medical disease to explain the symptoms. And I'd like to review how I ended up classifying those patients. I selected 78 of these patients because they had no definable disease. 72 of the patients had a disease like a goiter or high blood pressure, but it did not explain the symptoms. So in order to get a pure collection of patients with symptoms, physical symptoms, but no definable medical disease, I restricted the analysis to these 78 patients. After putting them on 3x5 cards and sorting them into groups and putting them here and putting them there, I came up with 4 definable groups of these patients, all based on how they appeared on the first or second interview when I saw them for the first time. And it had to do with the sequence of when they told me about their life situation. In group 1, the patients came in complaining about the life situation and then told me some physical symptoms. An example of that would be the woman who just recently divorced. She'd gained a lot of weight. She was aching all over. She had headaches. She had all kinds of symptoms. She told me about the divorce first and said, I feel bad, but I think the divorce and all the situation with my children has caused that from the stress. I just want to be sure I don't have a medical disease. And sure enough, she didn't. She thanked me, and I never saw her again. I had a note from her a year later saying that she was well and gone into a disease. So group 1 patients are very insightful, they're very aware of life around them. And I suspect they're like most patients who get a little problem, some spouse or friend tells them to calm down and rest, and they do, and it goes away. Life is full of stress. So the group 1 patients handled it well, did not get a disease, and did not have a diagnosis. Group 2 patients had all physical symptoms on the first interview, and they were full of the symptoms, the aches, the pains, the nausea, the vomiting, the diarrhea, headaches, whatever it was that was this physical symptom. And on the second interview, they would say something like, I have this bad situation at home or at work or in my job or with my children, and I just begin to wonder, could that be in any way affecting my physical symptoms? So they have insight, but it's slightly delayed from the group 1 patients. They realize life is stressful, and they're beginning to question the possibility that that stress is causing their physical symptoms. Group 3 patients of physical symptoms all the way through the first and second interviews. It's only when I ask them about life, well, how's life going with your family? How's life with your children? How's life at work? Are you happy at work? Are you happy in your job? Are you happy in your family? And they would say, well, not really, but I don't think it's got anything to do with my symptoms. So they admit to the stress, but they don't connect it. Group 4 patients are full of symptoms, full of symptoms, full of symptoms, and even when confronted about their family or asked about their family, they have no stress whatsoever. Yet when you talk to the spouse or the children, life is full of stress. Things are going on around them like we all have, divorces of children, separation of parents, separation of spouses, bad time at work, whatnot. They don't see that. It's as if disease has become a way of life for the group 4 patients. They're buried in their symptoms, and those symptoms generate a lot of behavior change in the family. They are in fact tending to control the family around them by their physical symptoms. If I then looked at those 4 groupings and analyzed those as to who had or did not have a diagnosis, the next slide will show that analysis. This slide is called Diagnoses Not Found Among 78 Patients with Symptoms Without Medical Diseases. And I won't go down that list now, but take time to look at it. Group 1 shows no diagnoses. Group 2 shows a list of diagnoses. In Group 3, a larger list. Group 4, a very long list. These are diagnoses that the patients believed they had. They were taking medicine for these diagnoses, or they were lining up for surgery for the condition. So they firmly believed they had these diagnoses, and nothing I could do in Group 4 removed those diagnoses. In Group 3, I was able to persuade the patient that half of Group 3 did not have the diagnosis they'd been given, and in Group 2, I was able to persuade all of them that they did not have the diagnosis. So once a diagnosis is given, and a lesson here is, once you make a diagnosis of a patient in a chronic disease, Ballant, who studied this condition of family doctors treating patients, Ballant said, once the doctor and the patient agree on the diagnosis, the disease becomes incurable. So a label is fixed if given by a competent doctor and not easily removed. So for that reason, as you'll see as I go on, I'm very reluctant to give anybody a diagnosis until I'm absolutely certain that condition is present. Another question I raise about this in my studies is, how common is the error of a false diagnosis? Well, what's amazing to me is how silent the literature is on this subject. About every 5 years, I do a Medline search looking for false diagnoses, diagnoses of non-existent disease, overdiagnosis of disease. And with one exception, I can find no studies or case reports looking at a population of patients to see how many patients in that population have a diagnosis of a disease they do not have. The one study I can find was in 1967 in Seattle, Washington, where they called in, they found 100 school children with a diagnosis of heart disease. I think there were 20,000 children in the study. Of this 100 patients with a diagnosis of heart disease in children, these are all under 16, only 20% had heart disease, 80% did not have heart disease. If you then looked at the disability of those children, the diagnosis of heart disease conveyed as much disability as did the actual presence of heart disease. 75% of both groups, 75% of the 80%, 75% of the 20%, had severe psychological or physical disabilities. So a label can be very harmful. How common it is among other diseases is simply unknown. So why the medical literature and the whole profession of medicine is not attempting to find out how much overdiagnosis there is puzzles me. I can't explain it. But it is silent, and I'm hoping that some of you might take it on to take a particular disease, go out into a population and see how many people actually have that disease. I suspect, but I don't know it, that part of the high cost of medical care is coming from patients who have diagnoses of diseases they don't have, yet they're consuming a lot of visits, a lot of medicine, a lot of even surgery. So the overdiagnosis of disease fascinates me, but it has not been fully explored. So let me turn now to the next book, Puzzling Symptoms, where I present in a series of case examples what I consider to be the 5 causes of puzzling symptoms. These are patients with chronic symptoms, not acute. This is not acute illness. These are chronic symptoms that last several months or more, that the patient is puzzled about whether or not they have a diagnosis for those symptoms. They don't have medical disease, or it wouldn't be in this book. My favorite question to these patients is, what are you doing in your life that you could stop doing? That's a very unspecified question. What are you doing in your whole life that you could stop doing? The second question is, what are you not doing in your life that you should be doing? That's a very unspecified question. As you say those 2 questions and watch the facial expression, you want to be sure that the patient goes into total listening mode, which I describe later in the book as a slightly dropped jaw, a kind of blank stare, looking down, and a very reflective face. And you want to be sure as you're having this kind of conversation that they're fully attentive to what you're saying and asking. Most will say nothing to both questions, but it sends them off in kind of a search for answers to those 2 questions over a period of time. This can take several weeks, even months, as you'll see in the samples in the book. The 5 answers to those questions, or the 5 generalizations I can make about those questions are: 1, the patient is coming in contact with a toxic substance, a toxic particle in their lungs, getting pneumonia, they're getting something on their skin, or they are eating something that's toxic, causing diarrhea. The second big grouping of patients who have puzzling symptoms is they have a toxic relationship with someone in the family or at work. The old clinical saws like, he gives me a headache, he's a pain in the ass, he makes me want to vomit. Those old sayings have a lot of truth in them, and they are revealing many times what's going on in a patient's life. One of my questions that I like, once I get to know a patient pretty well, is, why did you get sick today? Why didn't you wait till tomorrow to get sick? Or why didn't you get sick yesterday? And one of my favorite answers to that was a patient I had who had uncontrolled diabetes. She came in diabetic coma. After she woke up and was under treatment, I asked her that question: what happened today that you got sick today? She said, oh, that's very easy to answer. My daughter-in-law came by, and she stayed, and she stayed, and she stayed, and I hate that woman. And I started getting sicker and sicker and sicker, and then I started vomiting, and pretty soon I got very sick and came on in the hospital. So that daughter-in-law, if she shows up for very long, I'm going to get sick. That's the most straightforward answer to that question I've had in any patient. The next thing that can happen is you can be given a medical diagnosis that makes you think you have that disease, and you stop looking around for the real cause of that symptom. So again, a diagnosis is a barrier to getting at the root cause of symptoms. The fourth big grouping are those patients who self-inflict something on themselves. These are called either factitious diseases, malingerers, or the Munchausen syndrome, where they're doing something to themselves to produce the symptoms. The factitious disease people who do it just to puzzle doctors and to get a lot of attention drawn to them, or attention of the family drawn to them. We had a young girl who burned herself with cigarettes. We've had another patient who picked her gums with a pecan shell to put blood in her urine to make it look like she had blood in the urine, and on and on and on. Those are factitious diseases. Malingerers are those who do something to themselves in order to get money or drugs. They're after a cause or solution by having symptoms. And you see those in the emergency room with some frequency. And the third group, which are rare, are those with Munchausen syndrome, named after Baron von Munchausen of Germany, who told very tall stories, very dramatic stories. These patients tell very dramatic stories of what's going on with him, all of which are untrue. The final group of patients are those who I describe as group 4, who are so embedded in symptoms that disease and symptoms has become a way of life. One of my other favorite questions is, when were you last in robust good health? When did you not have these symptoms? When did you feel good and got up every morning happy and ready to go at life? And this woman told me, oh, I've never been healthy. My mother told me that the day I was born, the obstetrician dropped me on the floor, and I've never been healthy since that day. I've been sick every day of my life. So that's the most difficult of the patients to deal with. I frankly was not successful in penetrating that barrier. My goal in treating and seeing those patients has been to try to avoid surgery and try to keep them out of the emergency room, which is still a difficult task. And I'll end this puzzling symptoms with what I call the hidden disease. Hidden disease are those patients with addiction or alcoholism. That addiction is so buried and so out of their awareness and so denied that I've had patients deny they were alcoholics on their deathbed, vomiting blood from esophageal varices. So penetrating that denial is very difficult, and frankly, until a patient wakes up and admits to the problem, it's very difficult to help those patients. They can have all sorts of symptoms from the addiction, but not admit to you or tell you that they're addicted or that they're alcoholic. I want to turn now to kind of an approach I've worked out with patients that have these difficult and puzzling symptoms. And the next slides will show the kind of principles I use and the kind of suggestions I have to you as you see patients with chronic puzzling symptoms, or any patient for that matter. And I'll read down these so that I get all of them. The first is having the primary intention of being maximally helpful with each patient. Your one goal as you sit down, no matter what's going on, is to be helpful to that patient. The second injunction I'd give you is to honor the personal integrity of each patient. Make no judgment about whether this thing is true or not true. Accept it all on first go-round. The third is approach the patient in a mild state of awe. Watch and wonder and listening. The animal behavioralists say watch and wonder. If you can go into a watch and wonder, what does this patient have? I don't know this patient. I have no idea what they have. I want to listen in a mild state of awe and wonder as they talk to me and tell me about themselves. I always try to give the patient the first several minutes to talk freely. What brings you in today? What's going on? Very general questions, and let them talk until they quit talking. I try to make no distinction in the level of my interest between symptoms that are physical or social or psychological or spiritual. They all have equal value to me. I don't want to go down the trace of a medical disease search when the problem is over here in stress. So if you stress your questions too much along those 4 lines, any one of those 4 lines, you're going to miss the opportunity of looking at the other aspects of their physical world, the social world, the psychological world, or their spiritual world. I try to avoid cueing when asking questions about symptoms. We did a study when I was in Mobile, taking video pictures of doctors and patients, and doctors talking to patients, and very frequently the doctor would nod before the question, like nausea or nausea, very slight little shakes or nods, cueing the patient to answer yes or no. And one patient, doctor interchange, all of the questions were cued by the doctor. So in fact, the doctor was installing the history into the patient. Turned out to be a patient with abdominal cramps and nausea and vomiting and diarrhea, all preceded by nods of the head before the question was asked. So avoid cueing. It takes some time to make sure you're not doing it. My next one is accept the patient is having symptoms of unknown origin even at the initial visit. You don't know what they have, so why jump to something prematurely? Keep the diagnosis and symptom and naming of the symptoms out of your thinking. Learn to listen and reflect back what I hear until there's nodding agreement from the patient. Let me get this straight. You're having chest pain that's here and moves into the left shoulder, and the patient's nodding. You describe that accurately. Once you get a nod from the patient, you know you have gotten the clear definition of that symptom for that patient. Learn to gain and hold the full attention of the patient by watching the facial expressions so that you know when you've achieved full attention. The full attention of the patient, as I said earlier, is a slightly drooped face and a blank look. If they're moving their eyes back and forth, they're not listening to you. And you might as well stop, pause, and try to get their full attention before you go back into asking questions. I found that if I pay attention to the breathing of the patient, you see the breathing on the shoulder rises and falls as you breathe, and in some patients, if you match your breathing rate to the rate and depth of the patient's, you begin to see them calm down. I don't know what that is. I've read that before. I didn't invent it, but slowly breathing at the rate of the patient somehow gets rapport that otherwise is hard to get. So those are the little steps and suggestions I have for you on how to encounter any patient. The next several I want to go through are little clues and guides about the diagnosis and how you manage the patient. My first rule is to avoid specific diagnoses and disease labels until you're certain. I've said that before. I'll say it again for emphasis. When they say, "What do I have?" which is what they usually will say, you say, quote, "I do not know what you have yet." The little "yet" in there implies you're going to find out. But don't yield to giving them a diagnosis prematurely. "Oh, I think you've got so-and-so," and then they don't have it, you're going to have a hard time backing out of that. Use unspecified language when asking questions. Don't say, "Do you have pain on your upper lip, or pain here, or pain there?" Say, "Do you have pain anywhere in your body?" That allows them to search the entire body for pain. You're not directing them or cueing them to a certain type of pain. Try to avoid yes and no questions that will lead to a yes and no answer. Leave the questions unspecified, as general as you can. You might say, "Are you having any trouble in your chest? Are you having trouble in your abdomen? Are you having any trouble in your legs?" That's not telling them what they've got or if they've got anything. Embedding confronting type questions, you might say, "I'm wondering if there's any problem at home." So by wondering, you're not confronting that patient. And finally, I'll end by saying that I have the patient use a diary when appropriate. I'm suggesting in that the patient may be doing something he or she should not be doing, or not doing something he should be doing. By keeping a diary, they record the symptom, they record the time of day, and they record what immediately preceded that symptom. And I have them look at food, what they drank, what they were wearing, where they were, who they were with, what they were thinking, as many variables as I can so they can draw correlations between what's going on out here in their life and their physical symptoms in their body. So I've gone through those books that look at patients who had difficult and puzzling symptoms. Out of that, I've published this book this year, which is True Medical Detective Stories, in which I've drawn from some of those stories in the previous books and some new cases. So this is a fun book. It's 19 cases, all solved by listening, very low tech, very low technology approach to patients. I hope what I've said has been helpful. I want to thank Dr. Amina Páez again for all of her help in translating the books, for sharing her students with me. I want to thank the medical students in Venezuela that wrote me those kind letters, and I hope you'll all stay in touch with me in the future and send me some more letters. Thank you, Hamina.